Great. Well, thank you for coming today. My name is Marlise Perez. I'm with the Department of Healthcare Services and just so excited about our event that we have planned for you this week. But first of all, I just want to start this occasion with a very important land dedication. So I'm going to ask Virginia Carmelo if she could come forward, please.
Good morning, my friends. I would like to start out by honoring the Creator. I'm honored to be here to acknowledge our land and our ancestors. The presence here as the original inhabitants, heirs, and caretakers of our traditional ancestral tribal lands has been since time immemorial. Importantly, historically, these lands have never been ceded. In historical times, we were given names and descriptions by others. The long arms, the diggers, Cravilianos, Quiche, Fernandonios, Mission, Coastal Shoshone, and many more. But today, more commonly, we call ourselves Tongva or Tongve, as my ancestors before me would have said it. Tongve conveys the meaning of people of the earth. We are a people that identify with our land base. In 1994, this golden state acknowledged the Gabrielino Tongva Nation as the original and aboriginal inhabitants of the Los Angeles Basin. Still, we are among over 100 native California tribes lacking the status of federal recognition. Our Tongve ancestors were not nomadic. They thrived in a rich and dynamic maritime culture, interacting with a network of nearly 100 known villages and a clan and economic trading system that interacted with all of Southern California and beyond. Honorable the ancestors, as an integral part of the land and with a superb understanding of the land, enhanced our local biodiversity. They established and traveled the many connected paths, or all travel paths, from the mountains to the sea. We have maintained an ongoing relationship and knowledge of this beautiful land and its Mediterranean culture and climate. The city of Long Beach lies within the neighboring village of Toowoomba, one of our significant gathering places. Allow me to give you an accurate description of Toowoomba. Toowoomba is our Tongva tribal ancestral lands. It covers the entire Los Angeles Basin and the 4 southern Channel Islands. We identify this today as the greater part of Los Angeles and Orange counties and parts of Riverside and San Bernardino counties. Also, our lands were identified by natural geographical borders. In the north, we are bordered by the Santa Susana Mountains. That's what we call them today. The entire San Fernando Valley was home to many of our Tongva villages, such as Toowoomba, Cahuenga, and Pacoima. Those of you that are from this area might recognize those as Tujunga, Cahuenga, and Pacoima. Towards the east, we have the San Gabriel Mountains, as we call them today. We would have called them Hahaiuat, which means the snowy mountains. The snowy mountains are part of what we would know as the Sierra Nevadas, which traverse the entire state of California, well, most of it. And Sierra Nevada also means the snowy mountains. Today, in the area of the mountains, we have places such as Haramonga, Asusanga, and Cucamonga, all the way to Hurunga. These today are called Redbox, Azusa, Cucamonga, and Harupa. To the south, we have the natural features and boundaries of today's San Joaquin Hills, Santiago Canyon, and all the way to Aliso Creek. I come to you today from Hutuca, which you may know as Anaheim, the place where you can see all of the Los Angeles Basin on a very clear day. On the west, we have our coastal villages, one of them being Topanga. You may call it Topanga. And we have our 4 beautiful islands. The largest we call Pimu, and you know this as Catalina Island. The ancestors identified villages for the significant features of the area. The village names descriptions demonstrates our people's deep knowledge of their land. We are proud that Topanga is and has always been a flourishing center of abundance and creativity. On behalf of my ancestors, I welcome you here as we gather today. Awishkoneha te hefkopo eha. Peace, and may it be well with you.
The work you do for people across California is difficult. You prevent, reduce harm, treat, and help individuals obtain and retain long-term recovery. Sometimes you are the only one standing between them and standing in the darkness. I wrote this song about your work in California's substance use disorder field. It was written just for you. Your fears, your tears, your day-to-day fight, the light you bring. Awesome. Well, for all of my friends here that were sitting in the front row, I was going to call on you to come on up, but I ran out of time. So yeah, Julie and I will be here all week. So if you want us to sing it in your room or serenade you, feel free to ask. But so yeah, thank you so much. And That was a moment of vulnerability for Julia and I, so I appreciate you. But in all sincerity, you know, this conference and all the work that you folks do, this is my favorite time of the year. I always tell my team it feels like Christmas because I get to see you and get inspired by you and the work that you do. You're one of the largest reasons that I have been in this field for 20 some years because of your fight, your dedication. But I do recognize this work, it's really difficult at all levels. And I just want to thank you sincerely from my heart. And so now is the point where I go through all of that boring housekeeping stuff that they make me do, but they write it all out for me. So I'm going to try to go through it, but it's important information so your week can be successful here. So first thing is for workshops. I don't know if you've been glancing through the program guide. We have a lot more workshops this year for you, and I've heard that you're having a tough time choosing, so sorry about that. But we are going to have workshops this year over in the Hyatt, but also here in the convention center. So a little tidbit for you is if the workshop starts with a number, then you are going to be here in the convention center. We have rooms F, G, and H. And then also there will be coffee available here in the convention center and also over at the hotel. So for my coffee lovers, you'll be fine. There'll be enough caffeine throughout the whole event. So no worries about that. You'll also notice a lot of the DHCS team running around with scanners. That's super important. So you can get credit. So make sure that you get scanned in and out of those workshops. And then if you are here for some CEUs, and we have some new ones added this year, so excited about that. You will get scanned, but then also you're going to get an email at the end of each day. You have to complete the evaluations. So that's super important. And so make sure that you do that. Let's see, I've already run through all that. Oh, if you're having any problems with the CEU process, just go to the registration desk. I'll be happy to help you out. Ooh, this topic I love, lunch, woohoo! If you've been here before, the food is phenomenal. So you're gonna wanna know how to get it. So there is going to be lunch over at the Hyatt. There is an incredible tent that's outside. If you wanna be outside, you're welcome to do that. There's also seating all throughout the Hyatt. And there'll be a lot of people directing you where to go for lunch. And that will be for both days. Next up, we have bingo. Woohoo! So you got a bingo card when you registered. And if for some reason you didn't get one, those are available at the registration desk. And so, I love what they wrote. I'm going to read this for you. Let's see here. Who doesn't love a great game of bingo? We encourage you to play this fun game. I mean, who doesn't love it? I mean, do they not write it just like I would say it? So thank you, Kara. I am reading your talking points. But what's going to be important is you need to complete your card and turn it in by 4:30 on Wednesday at the registration desk. And so for those of you that are still with us on day 3, we're going to pull a lucky winner to win registration for next year's conference. So please participate in that. The next thing I want to announce, I'm really excited about this, and I just want to recognize my team, Javon and Tyler and Denise, because we have our first ever wellness room. So that is new here. It is right next door in room 204. And so please stop by. There's folks here from the Race and Gender Equity Project. So check it out. They're also going to be with us tonight at the reception. So hopefully you can stay for our reception. It's going to be at the Hyatt pool area. The cheese is so amazing. I've been looking forward to it all year and was talking to the chef yesterday. And I think I stressed her out a little bit because I couldn't stop talking about the cheese. There's going to be other things there. I will be at the cheese bar if you want to come talk to me. And then, oh my gosh, the photo booth is back. So I know I have team members that we're just pretty much eating the cheese and sitting in the photo booth. But anyway, please come out. You can, if you want to, you can talk to us. But more importantly, you can network with each other. So please come out for that. And now it is with my utmost pleasure to get to introduce my boss. Can you imagine being my boss? It is challenging. So please, like, if nothing else, I mean, first of all, she does phenomenal work, but she has to deal with me all the time too. But I'm happy to introduce Paula Wilhelm. She is our Deputy Director for Behavioral Health at DHCS. She came to DHCS in 2022 as Assistant Deputy. And on behalf of DHCS, she has probably the largest job in the department. She oversees licensing, certification, grants programs, policy development, implementation. Look, my next 12 pages about everything she has to do here at DHCS, Medi-Cal. And she comes with just such an extensive amount of experience. But on a personal note, she is a phenomenal person that cares about the people we're serving. And you're going to see that in what she's going to present today. And I'm just going to stop talking and let her take it from here. So thank you, Paula.
Thank you, Marlise. And just so everyone is aware, I was not told that I was going to have to follow an original song and musical performance. So I'm really excited and honored to be here today to help welcome you to DHCS's annual SUD Integrated Care Conference. And I'm Paula Wilhelm. I recently took over the role of Deputy Director for Behavioral Health at DHCS. And I know many of us working in the field look forward to this conference every summer. So I just want to take another moment to plug the amazing work of our conference team. We are excited to be able to offer you 48 workshops to choose from, which are organized into 8 different tracks. So we have tracks that focus on emerging trends in substance use, recovery and care management, data and quality improvement, advancing equity and reducing disparities, innovative approaches to engaging the unengaged, patient-centered care within a chronic disease management framework, strengthening the SUD delivery system, and innovation in SUD prevention. So be sure to check the program guide and pick out the sessions you want to attend. Be prepared to compete for some of the hot ticket sessions, and just know that our room monitors will close the doors on you if the seats are full. So get ready for the gun to go off when we all leave this room to get into those sessions. So before I share a few policy updates and thoughts on behalf of myself and DHCS, I also wanted to take a moment, like Marlise, to thank you all for the work you do. I know we have people in the room who are peers, counselors, clinicians, and support people in recovery. We have treatment program administrators and executives. We have our county behavioral health teams. We have our DHCS staff. We have a lot of policymakers and advocates and great thinkers, all of whom are linking arms to come together and advance this work for people with substance use disorders. So whatever your contribution, you are doing incredible, meaningful work in your communities and on behalf of your fellow Californians. And Marlise and I did not plan this, but she said something this morning that I was also going to say, which is that it is really because of the people in this room that I am in the role I'm in today. And I wanted to take a minute to share my origin story as a substance use policy professional. So I attended this conference back in the summer of 2016, and I was a health policy graduate student at UC Berkeley, and I was working on a project for the California Senate Office of Research as a student consultant. And so our state Senate had heard about an exciting new initiative called the Drug Medi-Cal Organized Delivery System, and they had asked their Office of Research to put together an analysis of risks and benefits and implementation issues. Again, this was back in 2016, just as the state, counties, and providers were beginning to work on implementing the DMC ODS. So when I worked on that research project, I met multiple people who are in the room now for the very first time, including Marlise as part of the DHCS team. I got to interview a lot of people who work in the field. I talked to treatment providers, county leaders, DHCS leaders, and some of our advocates. And by the time I was done writing and presenting that project, I knew that I wanted to keep working on substance use issues. And that is not only because it is one of the most fascinating and complex policy areas there is. I think anyone who knows me and works on my team knows that the thicker the policy weeds, the better I like it. But really, it was the people that I met in those very early years of learning about this field that blew me away with your passion and your dedication and your expertise. I don't think I had ever seen the same type of community and coming together and drive to help other people that I saw when I began to work in this field. So, you know, I may have come for the policy research, but you all are the reason that I'm still working here on the hard days, as Marlise said. So back when I did that initial DMC-ODS research, I got the opportunity to come to this conference and co-present with our colleague at UCLA, Dr. Darren Arata. And that event also was then, like it is now, an incredible opportunity to learn more about the field. So after that, I took a job with the County Behavioral Health Directors Association and am proud to have been part of the DHCS team since December 2022. So checking in to see who in the room is still listening. Whose first time at this conference was 2016 or earlier? I want to see a show of hands. Yes, I see them coming up. Okay, so we have some people who have been at this event and been in the field for a while. So what I've been thinking about in preparing to talk to you all is really the massive amount of change that you all have undertaken in the field in just those 8 years since I first came onto this scene. So I think, you know, people say that the only constant in life is change, and we have all been living that 10 times over in fewer than 10 years in this field. And I think a lot of you have been providing excellent services and excellent care for people long before that, and you continue to do that. But meanwhile, we've been riding these waves of change and engaging in a policy landscape that has really evolved and transformed significantly. So I'm going to share a few reflections on things that have changed since I first attended this conference in 2016. And I was a little nervous putting together the highlights reel here because I know it's going to be incomplete. We have all done so much work together to help people with substance use. So if I fail to mention a change or an initiative or an accomplishment that is at the top of your list of what you've accomplished in the last few years, please find me later and let's talk about that. So first, I wanted to lift up the fact that slowly but surely we have made significant investments in expanding publicly funded SUD treatment services in California and elevating those services within the landscape of behavioral health, so that SUD is considered an integral part of behavioral health and funded and invested in and lifted up in a way that we hadn't seen, I think, even just a decade or two ago. So we've made strides in reducing stigma and breaking down silos between substance use services and mental health, between substance use and other health and social services. And we're really not there yet, but driving toward a place where we can serve and support the whole person in front of us on their recovery journeys. So back in August of 2016, we had yet to even launch DMC-ODS, and as of August 2024, roughly 94% of our Medi-Cal population has access to the expanded evidence-based continuum of care that is available through DMC-ODS. Yeah, thank you. Thank you to everyone who has been working on this diligently for many years. I think our next speakers are going to share more about another massive change that is on the horizon. and that is the Behavioral Health Services Act, which you may also know as Proposition 1 or Senate Bill 326, and which you'll hear our team at DHCS and in the administration describe as behavioral health transformation. And one reason we're talking about that here today is the Behavioral Health Services Act does a lot of things, but one of those things is to authorize the use of Mental Health Services Act funds for services for individuals with substance use disorders. So not solely for those with co-occurring needs. Thank you. This change will hopefully meaningfully expand our county's ability to use a core funding source, Mental Health Services Act dollars, flexibly to meet the whole person behavioral health needs of their communities. You may also know that Proposition 1 enacted the Behavioral Health Infrastructure Bond Act of 2024, and we are authorizing a $6.38 billion in bond funding that will be used to develop behavioral health treatment settings and supportive housing for people with mental health and substance use conditions. So the state has now released our RFA for that first round of bond funding, and DHCS and the administration are actively partnering with counties and other behavioral health stakeholders to develop policy guidance to support county implementation of a new integrated planning process. And another exciting thing is that planning process, which is informed by a really robust community engagement and needs assessment, is intended to encompass all behavioral health funding streams and all behavioral health services in each county. So inclusive of SUD, inclusive of workforce development, inclusive of an array of important goals that we'll be developing together as a state and in each community. So you'll hear more about this today, but you can also find a lot of information on DHCS's website. Just search for DHCS and behavioral health transformation. A second change or area of progress that I wanted to mention that I've witnessed over the past 8 years is the way California as a state has really doubled down or possibly even tripled or quadrupled down on expanding access to medications for addiction treatment, or MAT. So since 2017, DHCS has allocated approximately $1.5 billion in federal, state, and opioid settlement funds to implement prevention, harm reduction, treatment, and recovery services grant programs. And a big chunk of that funding, I promise I will pause. My whole team knows I like to talk, but I promise I will pause if people want to cheer for your accomplishments, because this is really the point of this talk, is, to touch on just a fraction of the important work that people in this room have been doing over the past 5 to 8 years. So a lot of the funding that I'm focused on is administered through the California Opioid Response Project, which some of you formerly knew as the MAT Expansion Project. And I'm sure that everyone in the room is familiar with some of those programs funded under opioid response. So we're talking about things like the California Hub and Spoke System, which has expanded access to MAT through office-based treatment settings. We have the California Substance Use Line to offer free e-consult support for clinicians and prescribers who are trying to treat individuals with substance use disorders. And of course, we have the California Bridge program. I think we have some of those folks in the room today. I heard the applause starting, which locates navigators and hospital emergency departments to facilitate MAT access and coordinate follow-up care in the community. And so I want to call out that between 2020 and 2022, California Bridge engaged 276 emergency departments. That's over 80% of our hospital EDs in the state. Yes. And became the single greatest source of new MAT initiations. So again, thank you to everyone who has been part of an opioid response project and part of expanding access to MAT in California. A couple more of the things we're doing in this area. I'm proud of the fact that our team at DHCS has implemented a policy for all DHCS and certified SUD treatment programs and all DMC-ODS providers to either provide MAT directly or have effective referral processes and comprehensive assessment and access policies in place so that if you walk into a door in our publicly funded SUD treatment system, you should be assessed for MAT and promptly connected to that service. Recently, we've also released guidance that will enable the operation of mobile narcotic treatment programs, and we have made some funding available for startup costs. There is going to be a session on that, just calling out. So if you want to learn more about the mobile narcotic treatment programs, please check your program and join that session. And so in mentioning these MAT expansion activities, I think I've barely scratched the surface of the work that is being done. I'm going to continue with the highlights reel just briefly, and I want to call out a few of the ways that we have re-envisioned our SUD care continuum and expanded our ideas about treatment and recovery so that we are really doing innovative things with prevention, harm reduction, and recovery-oriented services and supports. So when we stop and think about harm reduction for a minute, I'd be curious to hear from some of you who have been working in the field longer than I have, if it feels like a milestone that our federal partners at SAMHSA have for the first time authorized the state and other states to use federal substance use block grant funds for syringe services programs. So we have seen block grant funding moving in a harm reduction direction, and we are excited that we just released guidance on this. It wouldn't be a DHCS speech if I didn't say the word behavioral health information notice. So if you want to know about the use of block grant funds for syringe services, please check out Behavioral Health Information Notice 24-024. Meanwhile, I think a lot of you are familiar with the naloxone distribution project that has been lifted up and gaining steam for several years. And I hate to say it, I have numbers from last quarter, so these are probably a little underestimating the impact of this program, but the naloxone distribution project has distributed more than 3.9 million units of naloxone to more than 3,900 organizations across California. And those organizations have reported using that naloxone to reverse more than 247,000 overdoses. So I think one of the next activities we're moving toward is to continue to help people incorporate harm reduction principles into our publicly funded services. And our team is lifting up a series of harm reduction summits. So the goal of the summits is to continue to reduce stigma and support and educate SUD treatment providers who are seeking to take a harm reduction approach in your programs. So if you want to participate in one of these harm reduction summits, registration is currently open for the first two. There will be one in Shasta County in October of this year, one in San Mateo County in November, and then we'll be scheduling harm reduction summits in Fresno, Los Angeles, and San Diego later this winter. So while we have a long way to go, I think we've also begun to work more consciously and consistently to ensure that publicly funded behavioral health services can really meet the needs of California's very diverse populations. One of the projects that we are doing that I just learned about is the Recovery Services Project. This is a $75 million investment in increasing the number and quality of culturally responsive behavioral health recovery services and programs statewide. So you might have heard of the Health Equity and Access to Behavioral Health Recovery Services because it has a cool acronym, the Hear Us program. First, we established a community-driven process to develop behavioral health recovery services standards of care. And next, we'll be funding over 100 organizations directly to begin providing culturally responsive recovery services or begin to develop new culturally responsive programs. So I think to bring us home and move us forward in our program today, I want to celebrate and take note of something that has not changed since 2016. So in 2016, California was the first state to implement a new Medicaid demonstration to cover a comprehensive continuum of care for SUD. That was the DMC ODS. Today, we are still a leader in launching innovative behavioral health programs and policies. And I actually think this should have been on the bingo card. If you hear in one of your sessions today, California is the first in the nation, please take out your bingo card and give yourself a bonus point, because you will hear it, because we like to be first. So just a few of our firsts. We have become the first state in the nation to receive federal approval for coverage of contingency management in our Medicaid program. Does anyone in here work on a contingency management or recovery incentives program? Yes, raise the hands high. Thank you. This is really exciting. To date, 74% of the Medi-Cal population lives in a county that now has at least one contingency management provider being funded through Medi-Cal, right? These programs may be funded in other ways, but we're excited to bring it under the Medi-Cal umbrella. You're probably aware that our CalAIM waiver also included a first in the nation approval to cover a targeted set of pre-release services, including MAT in Medi-Cal, for individuals who are preparing to re-enter the community from prison, jail, or youth correctional facilities. Yep. And I think that the people in this room know what a powerful opportunity that is, given individuals re-entering the community from incarceration are over 100 times more likely to die from an overdose compared to the general population. Making sure that we get in and connect people to services and connect people specifically to MAT is a really exciting piece of progress that we're going to be seeing in our communities in the coming years. So we are also continuing to push the envelope in Medi-Cal in other ways. We have, I think one thing I haven't mentioned yet today is just that the foundation of everything we're doing is our behavioral health workforce, right? And a lot of you in the room are part of that workforce. And we can't have one conversation about policy goals or achievements without hearing and knowing that we need to build up our workforce. And so we are starting to do that in a lot of different ways. But one proposal that I'm excited about, our BH Connect waiver, includes a request to our partners at CMS for $2.4 billion in total funds over a 5-year period to support behavioral health workforce development. So inclusive of the substance use disorder treatment workforce, something I'm excited to engage you all on in the next few years. We are also going to be having a conversation ongoing about how we measure quality in SUD care. I noticed one of our tracks at this conference is on quality measurement and improvement. So we are really starting to think about what outcomes we expect to see if we are doing our jobs well. Since 2020, even much more recently, we've launched a comprehensive quality strategy at DHCS, a new set of behavioral health accountability measures. We've offered quality incentive payments, which we plan to continue in BH Connect. And one more note on behavioral health transformation, or the Behavioral Health Services Act. One of the parts of that I'm most excited about is a mandate to establish statewide behavioral health goals and outcomes measures, which will all be working individually on in our communities, but also driving toward collective measurable progress in the areas that we identify. So I hope that you all are as excited as I am about some of the progress we've begun to make together in the last 8 years, knowing that we still have a lot to do. I hope this conference can be a space where we continue to come together to build community, learn from each other, and recharge our batteries on the days when it's hard to continue carrying this work forward on behalf of all the people we serve. So thank you again for your work and your dedication. Thank you for welcoming me into this universe 8 years ago and keeping me motivated every day since. I'm really looking forward to meeting more of you over the course of the conference, and I will now turn the mic back over to Marlise and our conference team to keep us moving. Thank you all.
Thank you so much, Paula. Isn't she phenomenal? Great. Well, we are going to switch now to one of the projects that Paula highlighted is our Behavioral Health Continuum Infrastructure Program, and we have a video for you.
Those that need help.
Data, statistics, just looking at the news will tell you something is very broken. Opioid use disorder, substance use disorder, those numbers are absolutely through the roof.
People really genuinely want things to be better, but a lot of people don't understand behavioral health.
There's a lot of fear, a lot of guilt, a lot of understanding what behavioral health is.
These aren't moral failings. These aren't people like who chooses to have a mental health disease, who chooses to have a substance use disorder. Nobody chooses to be homeless.
We're at roughly 225,000 unhoused Californians. There's a need everywhere. If you have a waiting list and there's people trying to get in a drug treatment facility, there's a whole bunch of people not getting in there.
We would be up in arms if it was someone with a heart attack who arrived at the emergency room and they told them, sorry, we can't serve you today because we don't have the capacity.
And if we have the power to do something to help our community and to help those that are suffering, why not do it?
This is historic. There's never been an opportunity like this to build capacity in this kind of way. Goals for this epic level of investment is access to care.
The communities that need mental health care, behavioral health care the most are the marginalized, hard to reach communities. It can be our inner city, low income communities. It can be rural communities.
We want to reach out to as many, many people as we can and say, look, this is not an isolated issue. This is an issue that affects every single one of us.
Well, it's important that our community have access to care because without having access to care, you can't really improve your life.
I used to come here for hope. I was hoping to see a person that can speak to me spiritually, culturally, and about our heritage. I found it here. This is a blessing to me, and I'm sure to many, many others.
That's really the mission. The mission is to see this organization be the light of the Native American community, be that beacon where they can see it from afar and come and say, hey, I need help. And whatever it is they need, we're going to make sure they get it.
So one of the things that CryHelp is known for is serving individuals from diverse socioeconomic backgrounds. As of last year, 95% of the persons that we admitted into treatment were Medi-Cal eligible beneficiaries. And we'll look to extend that reach here in Lincoln Heights. From the time that you pick up a phone and you talk to a receptionist, to meeting with an intake counselor, meeting with a primary counselor, working with your therapist, all the way up to the medical director. We seek to employ persons who are Spanish speakers. And we believe that the infrastructure that we're looking to launch in the Lincoln Heights neighborhood will be something that is culturally responsive and can provide services to adults who are monolingual Spanish speakers.
ABC has what we call a full continuum of care, which means that we can take somebody in at the detox level. We have a psychiatrist for a medical director, so we can pay attention to their mental health disorders as well. And then we can transition them and slowly disband the structure down to the outpatient level of care, and we even provide housing.
The benefit of our programs is it saves families, it mends families, it brings them back together. People are living a healthy, fruitful life. So I think in all aspects, it benefits even people that don't have addiction.
That's a lot of recovery and a lot of human beings that are getting treatment they couldn't get before.
I can't stress enough. So facilities of our type would never be able to afford to build a project of that scope. It's unprecedented and it's historic. The help that our communities are going to receive is going to multiply, drastically over the next couple of years.
Transgender and conforming intersex people need to have access to care. And that is one of the reasons why we exist as an organization, so that we can not just advocate, but also, in some ways support and provide the care that our community needs.
The TGI community that is homeless is out in the Hollywood and West Hollywood areas. So for us, that is our epicenter. That is where the need is at.
I've never seen a grant this significant. You intentionally and meaningfully invest in the livelihood of people, then that's how you create the change, right? And make the difference that needs to happen in people's lives.
These are things that are going to be truly lasting. And so when the day is done, there'll actually be these physical structures that build out that access. Even though it's a tremendous amount of change we're taking on in California, that once we actually arrive and get there, it's going to be phenomenal. And then I want to be a model for other states and help them get there as well. Because I don't just care about people here in California, I care about anybody that has this disease.
For myself, treatment on demand was essential. It saved my life, and it has saved millions of lives across the United States.
think we often hear about the issues, but we don't hear about the success enough. Anytime we expand more resources for people that are marginalized and disenfranchised for the community, we're bringing hope to the community.
Great. I have to follow that. I was like a little teary-eyed. So next, I have the utmost honor and pleasure to bring forward two incredible gentlemen and speakers that are going to stand on up and walk on over here. So first is Tyler Sadwith, and he is DHCS's State Medicaid Director. And for those of you, you have seen Tyler here before as our Deputy Director and also as our, this is my seat, so you can't sit here. So either one of these, sir. Thank you, sir. And he also, I first met Tyler with the Drug Medical Organized Delivery System. He was our counter partner at CMS. So we stole him over here into California, and now he is in this incredible role for California. And then most of you know this incredible gentleman, Dr. Galley, and sometimes I call him the secretary. And every once in a while, when I'm brave enough, I call him Mark. Not to his face, though. This is the first time this has happened. No, but for those of you, I have a lot of privileges in my role, but one of the utmost privileges has been getting to know Dr. Ghali. And I was trying to think of how to introduce him, and the best I could come up with is to say there is nobody in California that cares more about this field than Dr. Ghali. And that is the best I could say about him. And it is an authentic, and he is always fighting for you all day long. And so what we want to do right now is just really have a time of a discussion, because there is, like Paula mentioned earlier, so much happening in the substance use disorder field in California. And so I have some questions for them that I have prepared, and then I have some secret questions that they know nothing about. I'm just totally joking. So with that, I'm just going to jump right in. And I think this one just really sets the stage of, and we'll start with the secretary. What personally drives you to improve SUD prevention, harm reduction, treatment, and recovery services?
Well, first, this is such an incredible room. I mean, sitting up here and seeing how full it is, there's not a seat open anywhere. There are people up against the wall. The lobby has lots of folks as well. I mean, I don't know that there's a conference like this on almost any health issue anywhere in California ever. And that is such an important message for the state to hear, for state leaders to hear. But most importantly, I hope for all of you to see, feel, and hear that you are doing this work with teams all across this amazing state, and lots of people on those teams hungry for solutions, hungry for interventions. And I have a lot of moments to be proud in my job. This is one of those moments, just to see how intense this field is and what you all bring to it. So I know there's a lot of give yourself a round of applause or a pat on the back, but let's do that because this is amazing. And I'll just take another moment of privilege to thank you, Marlise, for your incredible leadership, your vision. I would have said the same thing about you. You are the person at the state that I see leading on this issue as much, if not more than anyone. And I'm grateful for the honor of having a chance to work with you. Paula, great introduction to your new role, but you've been at this a long, long time as well. And Tyler, I think it is a statement in this state that has so heavily leaned physical health for so long to pick our Medicaid director, not just the director of substance use disorders or behavioral health, but all of Medicaid in its vision to be somebody with a deep-seated background in behavioral health and substance use disorder treatment. And it is fun to be in these conversations with Tyler. Paula and Marlise on a daily basis, where they elevate the issue, where they make sure that it's not only not forgotten, but that it is front and center. So to your leadership and Michelle Boss, who isn't here today, but also leads that way, I'm really proud to work with you. Okay, so now to answer your question, what motivates me in this space? So some of you know I trained as a primary care pediatrician and cared deeply about adolescent health. And the first job I had, actually started it during residency, and right after residency was in the Bayview Hunters Point community of San Francisco. And I had the privilege of starting basically a teen clinic in Bayview. And the issues of substance use disorders, whether they directly impacted the young person in front of me, their friend group, or their family, was profound. And then fast forward my work with the transitions clinic in the same community, looking at people coming out of prison in particular and into community, and looking at the obvious data that people coming out transitioned with nothing. And when they did that, they found their way back into situations that were harmful to their life, right back in the emergency room and right back arrested, then moved to LA and run all of the health services in our juvenile detention facilities, and to see it front and center again, substances wreaking havoc in people's lives, and not enough service, not enough commitment, not enough focus on what we can do in those spaces. Again, connected to the adult justice system, the work that I had the privilege of leading and working with an amazing team on housing and homelessness, in our child welfare system. I mean, an underbelly and an important piece of this is the connection to addiction and substance use disorders. And I think over that time, seeing and feeling the real lives impacted by these diseases, and the fact that we had oftentimes nothing, certainly not enough to address them, fuels my commitment to fighting with you to not just make sure that this room is full and we need a bigger room next year so it can be even more full with the workforce doing this work, but that you all have what you need to support those you are there to support in their life, in their journey. And I was on my drive in thinking a little bit about how the science of this field has a long way to go. We still don't have the kinds of interventions that we have for some other chronic diseases, whether it's diabetes, hypertension, heart disease, pick your thing. This field has a long way to go, but as we develop those tools and we see them more and more available, whether they're actual medications and treatment, or whether it's an intervention like contingency management or other types of treatment services, making sure that they're widely available, whether you're in Del Norte or Imperial or any county in between, is a commitment we have. And I think what fuels me most are the lives that I've seen destroyed, but also, even more importantly, the lives I've seen transformed and recovered because of the work that all of you do. So long answer, but yeah, that's what drives me.
See, this is why it's so fantastic. Tyler, we'd love to hear the same thing from you. What personally drives you in this field?
Happy to follow Dr. Galley anytime. No, but in all seriousness, just to start, this is so refreshing, reinvigorating. It's so rewarding to come here and just see all of you show up. You show up day in, day out. You help people reclaim their lives. And this is why I show up too. Substance use disorder, like most people, if not virtually everybody in this room, is something that has impacted me personally. I have witnessed and felt the impact of substance use disorder my entire life. One of my parents suffers from substance use disorder to the point where they can no longer manage their own affairs or live independently. I serve as power of attorney for my mom, who has alcohol-related dementia at this point. I have lost friends to substance use disorder, like many of you. I've lost friends to prisons, to the streets, and to death from overdose. But the thing about this disease is that it's that coin. There's that tragedy and there's that pain. But on the other side of that, there's that beauty. And I've witnessed the miracle of recovery. I've seen I've seen how someone can have full access to the continuum of care. They can be in the throes of addiction, so hopeless, so broken. And through the work that you do, inpatient withdrawal management, residential treatment, intensive outpatient treatment, sober living, medications along the way, and community-based recovery groups, I've seen how that can help someone literally have a second shot at life, regain custody of their children, get a job that they feel proud about, pay taxes, stop at stop signs when they drive. This is what motivates me. I've been in this field for over a decade, started in the federal government on national policy for substance use disorder in the Medicaid program. I've worked with other states on behavioral health reforms, and I had the privilege of serving as deputy director for behavioral health at DHCS. And like Dr. Galley said, I wouldn't have taken on this new role if the secretary and this administration and our governor was not so deeply committed to behavioral health and to substance use disorder specifically. It remains a top priority, and that's why I'm honored to serve here. And I'll end on a lighter note. I'll prove to you how important this is to me personally. Tomorrow's my birthday, and there's nowhere I'd rather be than at this conference.
We're totally going to sing happy birthday to him tomorrow. So over the past several years, California has pursued major behavioral health initiatives, including but not limited to CalAIM, the Children and Youth Behavioral Health Initiative, Medi-Cal Mobile Crisis, 988 implementation, the Behavioral Health Continuum Infrastructure Program, Behavioral Health Bridge Housing, Medication Assisted Treatment Expansion Project, and just so many that Paula also mentioned this morning as well. But how do these initiatives all work together to improve services in California? And we'll start with Dr. Galley.
Sure. First, I think it is quite an amazing statement that despite the disruption of a global pandemic and a number of other challenges, that this administration, through the governor's leadership and an amazing team at agency and DHCS and just in our communities and counties, have been able to propel forward so many meaningful investments and ideas. But they really are for naught if they don't connect deeply to people. And so when I hear the laundry list, whether it's letters or the names of the program and who's doing what, I simply close my eyes and see the person who has a chance to have their life reclaimed, transformed, improved. And in it is, we often overplay this word continuum, but at the center of that person is this continuum of opportunities within all of these programs. And on one end, there is a focus on prevention and early intervention. And on the very other end, there is those transformative programs that emphasize treatment, support, and recovery for those who might have the greatest challenges. And so as I think about our investments in these programs, I think about the opportunity to leverage. One of the guiding themes is leverage here. We know that California on its own can only invest so much. The Behavioral Health Services Act is a significant funding source, but it's still limited. So figuring out how to leverage our federal dollars as much as humanly possible is, I think, a connected theme as well. So it's the second piece in my mind. First, person in the center. Second, let's be ruthless about getting as many resources as we can. The third piece is those resources don't make a difference if we don't figure out this workforce piece. Today, seeing this gives me a lot of confidence that we're going to get there, and supporting and figuring out how we're going to propel that workforce forward, not just more of what we already have, but where are those gaps and the types of positions and who does what and how they work on teams. I think that's another connected theme here. And at the end of the day, the people who are affected can only, that aggregate story across a state of 40 million people only gets told if we think about our data and our ability to collect it and share it about those improvements. So again, anchored by the person in the center, this is about getting as many resources as we can get. It's about really transforming the people who have an opportunity to make those resources make a difference in people's lives, and then telling the story through the data and the information that shows that we've made improvements. And if we do all of that with these great, amazing programs, I see a future of not just sustainability, but scaling across this great state in this important area. And I'm appreciative of the team that's helped make that happen.
Thank you so much. This question's for Tyler. So why has the administration invested heavily into the provision of medications for assisted treatment?
I think it was really helpful to hear Paula describe some of the results that we've seen from initial investments over the past 6 to 8 years. I mean, taking a step back, the list of acronyms, the list of projects we're doing, right? It's like alphabet soup. We could sit here and run out the clock talking about the amazing projects and the amazing initiatives that we are investing in, because in many ways we're in arrears, right? We have been, this field, substance use disorder in particular, has been underinvested, under-researched, neglected with funding investments, policy reforms, prioritization from administrations. And so I think right now, collectively, we're experiencing decades worth of catch-up compressed into a span of several years. And it's quite overwhelming, but it's also a once-in-a-generation opportunity for us to sort of take advantage of what we've been waiting for. I think medications for addiction treatment is sort of a perfect example of that. We know medications work. We know medications are effective. We know medications are the standard of care for alcohol use disorder and for opioid use disorder. We know that medications reduce emergency department visits, hospitalizations, they reduce overdoses, they reduce the spread of infectious diseases like HIV and hepatitis C. They improve self-reported quality of life. They're life-saving. They are literally life-saving. Medications are the standard of care. And so, thinking back to 2016, 2017, when SAMHSA released the state opioid response, or the state targeted response funding for the first time, California doubled down on medications. And it's about, I think that the theme of this conference, is about making the system work for people instead of making people work for the system. And I think that's how I see medications flowing into every single setting in our healthcare delivery system in California, through the California Bridge program, where we have the majority of hospitals, over 80% of hospitals, with a navigator in the ED facilitating access to medications, facilitating continued care. We see that result in 3 times the rate of follow-up care in the community. It makes people show up for their next appointment. We've seen medications in jails through, over 30 county jails have participated in funding and technical assistance to implement MAT. The California State Prison System, CDCR, has implemented their integrated substance use disorder treatment program, medications for addiction treatment in state prisons. We are pretty ahead of the curve on that. I think the Cal-AIM Justice Involved initiative sort of weaves it all together. I think as Paula shared, we know people leaving prison are 129 times more likely to die of an overdose in the 2 weeks after release than the general population. And so with the Cal-AIM Justice Involved, we are screening people for Medicaid eligibility inside the four walls, enrolling them in Medi-Cal, screening for medical and behavioral health conditions, and starting treatment, including medications, with facilitated handoffs during that release period, so that in the community, they're met with an enhanced care management provider, they're met with a follow-up medications provider. I think that alone has sort of the potency to address some of the most vulnerable and sort of crucial moments for our population with the greatest need and the greatest disparities, including perhaps addressing some racial inequities that we know mass incarceration has brought about in California and across the country. We have doubled down on medications and FQHCs in mobile narcotic treatment programs, medication units for narcotic treatment programs, medications in every substance use disorder treatment provider that is licensed or certified. As Paula mentioned, it's now sort of a state requirement for people to be assessed for medications, counseled about medications, and either sort of that facility has to either offer medications directly or facilitate and coordinate access to medications during their course of care. This is the standard of care. There's no waiver anymore. It's not a specialty thing. It's not something that provider does over there. We have to weave it in so that wherever someone shows up, whenever someone is engaged by outreach workers, when they call the hotline, when they hit the ED, when they seek treatment, when they see their primary care physician, the standard of care is available to them. That's making the system work for people.
Thank you, Tyler. All right, this one's for you. This one is a softball, but I know you're going to love it. So Paula talked a little bit earlier about Proposition 1. And so I would just love for you to talk to everyone here. How is Proposition 1 going to impact the SUD field?
Yes, a softball, especially for this group. So, no secret, when I took this job 5.5, almost 6 years ago, one of the earliest ideas was, how do we reform MHSA? And there's a number of reasons why that was a high priority to me. It was driven through the experiences I had myself in LA and San Francisco and sort of what I'd learned across the state. And one of the top few reasons was, how the heck can we have this landmark legislation and really leave substance use disorders on the sideline? And so what we tried to do, and I think did a pretty good, not a perfect job, I'm sure each of you could come up with 5 misses in that proposition, but as it relates to substance use disorders, we didn't just keep talking about it by transforming the name from mental health services to behavioral health services to be inclusive of SUD services, but we really arm wrestled with a lot of people in the classic mental health world to say this had to be a priority, that this had to be on the menu of things that the dollars could be spent on in a serious way. So even though that transformation is still a little time off, those conversations in the next months and years about how to actually do that on the ground, how to actually integrate behavioral health services in a street, clinic, housing setting, how to build that bridge between physical health and behavioral health more solidly, will include substance use disorders in a major, major way. And it is the gateway to the innovation and the ongoing scaling of what we can do in this field. It is what's going to fuel not just making sure we have enough of the workforce, but that workforce is as elegantly and sufficiently trained as I know you want that workforce to be. So to me, it's really this gateway opportunity to not just be on the map, but to deepen the state's ongoing commitment. And it does, unfortunately, start with both a commitment and the funding. And I think Prop 1 has done that for this field.
Thank you. Tyler, why are harm reduction services so important? There's a time limit, Tyler.
That's a softer ball.
No, I'm making these easy.
Yeah, when I look at the agenda and the tracks for this conference, I see harm reduction sort of embedded throughout the continuum of care. I think harm reduction is a really big tent. It's a really big umbrella. And historically, maybe to some, harm reduction has meant a syringe service program that sets up a table in a park somewhere. And that is harm reduction. But I think what we're talking about in a lot of the tracks here is really about weaving harm reduction principles and philosophies into addiction treatment settings and protocols and philosophies so that this system is designed to care for people with substance use disorder. Substance use disorder is a chronic disease where recurrence of use is a symptom. And for too long, I think our system has been set up to be designed for that unicorn patient who is ready to commit to 100% total abstinence from every single substance on day one. And we know people with the greatest need are not that unicorn patient. People with the greatest need maybe are pre-contemplative. Maybe they have ambivalence about even calling for help. Maybe they don't want to give up cannabis use. And so it's incumbent upon us to redesign our service delivery system, take all of these massive new investments in physical capital like brick and mortar infrastructure through the Beachit project, in human capital like the $2.4 billion in investments that we're planning to make in the behavioral health workforce through our BH Connect waiver, through new investments in enhanced rates and Medi-Cal for new services. All of that is well and great, but if we don't embrace a harm reduction, patient-centered framework for how we engage people and reach out to people and accept people in our system, the people with the greatest need are going to be shunted off to the sidelines. And I think we're going to hear from innovators in this field. Tomorrow's plenary in the morning, counties will talk about how they're redesigning their delivery systems. We heard from Paula about harm reduction summits that we are convening across the state. We really encourage you to look those up. We've commissioned ASAM to develop clinical guidelines on how to incorporate harm reduction philosophies into treatment protocols for admission, discharge, retention. If you look at the data, the rate of administrative discharges is astronomically high. It's in the 40%. I think, harm reduction is about low barrier care. It's about life-saving supports like naloxone. It's about life-saving supports like medications. Even if it means keeping someone alive so that, they're engaged and maybe one day they're ready to begin a full-fledged recovery journey. But if we don't keep them alive until that day, they'll never get into recovery.
This one's for Dr. Galley. So the administration has linked housing with healthcare. Please talk about this connection.
So I think probably everyone in this room knows, for those suffering, struggling with addiction, and frankly, almost any chronic disease, it is infinitely harder to find a pathway to healing, recovery, and thriving when you don't have a house. When you don't have a place to call your home, where you don't have a place to store your meds, to invite a friend, to cook a meal. And in a state like this one where we have such amazing wealth, it is hard to imagine that we can't figure it out for everyone. And because our sort of social service system has not, we have unfortunately had to make this one of the key health issues in California. And so this administration, our entire agency, DHCS in particular, as well as social services, has found a way to do that in spades and make it an important, not just only place of investment, but priority. We often talk about the creation of investments, and those investments are dollars, yes, but it's also a creative, innovative idea of how to do this better and smarter and at scale in a state this size. And I think the fact that we have so many people, you saw it in the video, experiencing homelessness, that we have a long way to go, but making sure we anchor it to people's health has been a key strategy of ours. And then the second thing to say, and I think that resonates most in this room, would be it is hard to experience homelessness in California. It is a full-time job. It is stressful. And not only is it hard to manage a challenging disorder like a substance use disorder while experiencing homelessness, but the fact that that experience incites and makes it not just harder, but worse is also one of the big mountains we need to climb. So this state will continue to prioritize housing those with chronic illnesses, housing those with behavioral health conditions, and housing those with substance use disorders in specific as a priority, not just of Prop 1, not just of BH Connect, but we hope in everything we push out. And I know the governor shares this view. He and I talk about it quite a bit. And we look to all of you to help us not just have the investments be cool looking on paper, but actually transform the lives of a lot of those that you serve every single day.
So I'll start with Tyler. Just any closing remarks that you want the audience to hear.
Just thank you, honestly. I know sometimes maybe the state can seem like some faceless bureaucracy. You never hear from us except when it's bad news, maybe, but we see you. We acknowledge the work you do day in and day out, helping people save their lives. We are showing up to work every day to support you, to make it easier for you to help people. This space is for you, and from all of us at the department and this administration, we just want to say thank you for all of the work that you have done during the pandemic and in these transformative years. Thank you.
Any closing remarks?
Yeah, just first, I'll echo the thanks. Really, the motivation to do the work that we have the privilege of doing happens because of this and the people's lives that you're a part of. So much of what the Department of Healthcare Services and the state focuses on and what we broadly call or lazily call the safety net. And these are often programs that are funded through state and federal dollars. Medicaid, big safety net program, probably the chief safety net equity tool that we have in California. But one of the conversation points that we have more and more had at our leadership level and with partners across the state is how do we move the prominence of issues like substance use disorders, not just as a safety net issue, but an issue broadly in healthcare. And one of the things I hope you will help us think about is how do we push our commercial plans and other insurers to really prioritize substance use disorder services and treatment so that wherever you go, no matter what your income is, no matter what your insurance status is, this is a front and center issue in what happens in your care. And we're a long way from that. And frankly speaking, if the commercial side of the industry did their job a little better, the work that all of you do would just be a little easier and a little bit more focused. So, yeah, I think it's probably wasted on some of you, but some of you, I think it resonates because this is the next frontier. How do we not just make it as a part of the Behavioral Health Services Act in California, but how do we make this a core issue to what people pay for in their day-to-day insurance? You're all probably paying a little bit of your paycheck for a premium to get healthcare, and that healthcare often doesn't prioritize behavioral health and substance use disorders, and California's on a mission to make sure we work with those who do business in California to make it a more prominent piece. So I think that's worth saying because I think that really helps us arrive as not just a fringe issue, but a core issue to the healthcare system.
Can we give a round of applause to Dr. Galley and Tyler? Great. Well, this concludes our plenary session. And in the words of Paula, run to your workshops. And so once again, they're here and then over at the Hyatt. And we'll see you at lunch. Thank you.